our genetic code. And it's very simple. It's just made up of 4 letters, A, T, C, and G. And A always goes with T, and C goes with G, right? And it's different combinations of those letters that give you your genes and the genetic code. Okay? So, and each of those, when they get form 3 of those, AAT or ATT, this gives you a little block, right? But if one of those, if there's a mistake, then it gives you the wrong message. And in Olliers disease, so you have one cell, mum and dad come together, the egg and the sperm, and there's no mistakes. And then they divide and you have 2 cells. And then you get 4 cells. And somewhere between 4 and somewhere along the route, there's a mistake. And that mistake we now know because in 2011 we reported that the mistake is in a gene which called IDH1, IDH2. You need just to know that that's the gene. And the mistake that occurs changes one amino acid, one of those triplets, into another triplet. There's one single letter goes wrong. And that is held then in one cell. And that, we'll call that the blue cell, with the mistake. And that divides. And every cell that divides will now carry that mistake. Okay? So if it occurs very early on, there'll be more cells around the body carrying that mistake. If it occurs a bit later, there'll be less cells carrying that mistake. And so if this cell here, this is the cell that might go to be your big toe, and this cell goes down to be your little toe, and this cell goes to your brain. And wherever those cells go in the body, in the very early stages of embryonic development, the mistake will be there. Okay? And that mistake seems the most dominant feature of this disease is the abnormality of the cartilage. Okay? But that's how it happens, right? It happens very early, but remember it happens after the egg and the sperm come together. So it's not inherited. It doesn't come from mum and it doesn't come from dad. Okay? It's just bad luck, right? And it's not because we've been smoking too much or drinking too much or laughing too much or anything. You know, you can't, there's no reason that we understand that this occurs. And it happens to nice people, and not nice people, and happy people, and grumpy people, and black people, and white people. It happens to everybody, right, of those affected. So there's not a particular group. And this is what we end up with. So just let's go and look. So this is your shin bone here. This is your ankle joint. And here's your growth plate. Remember this? I told you about the growth plate. This is where the cartilage is. This is your growth plate at the ankle joint. And normally, this is just a picture of it. This is your growth plate here. And it's very sharp. And as the cartilage, it turns very sharply into bone. And again, this is just when you see down a microscope. This is your cartilage at the growth plate. And then it turns down here into bone. Okay, so I'll just show that over here. This is a bone, and you have your normal growth plate here, and it's very sharp, and it turns into bone. And that's just a bigger picture of it. Now this is an experiment that was done to try and understand what does IDH1, what does that mutation do? So I hope this doesn't upset some of you, but people make mice. Mice can give us a lot of insight into disease. And they're very nice to the mice. They're all very well fed, and they're kept warm, and they're given nice food, and very expensive looking after these mice, and they're all treated very well. So they made a mouse, and they introduced the IDH1 mutation into the cells in the mice. And it shows what happens. It's a really beautiful experiment. There's a group in Canada that did this. So this is a normal bone, and this is a normal bone. And this is the growth plate in the mouse, okay? The healthy mouse is depicted by the red. And you can see there's a very clear demarcation between the cartilage and the bone, okay? So the cartilage turns into bone, and the children grow normally. And actually, when you reach puberty, that cartilage of the growth plate stops growing, because otherwise you continue to grow forever. That turns into bone, and you stop growing. The mice with the cartilage, with the IDH1 mutation, can you see the difference?
Mm-hmm.
That this cartilage here, this growth plate, most of it is fine, right? But you see, it doesn't quite control it. You can't see it as well, or you can't hear.
Mm-hmm.
But instead of turning sharply into bone, some little nodules don't turn into bone and continue and grow as cartilage. Okay? So as you grow, as the child grows, so I just put this in here. This would be the growth. This is a child, for instance, and here is the, this is your normal growth plate, but here you will have these little nodules of cartilage, just like I've shown you in what they did in the mouse. And you can see here that as a child grows, you can accumulate these little cartilage nodules as the child grows down the length of the bone from the growth plate. Does that make sense, right? And the downside of that is that, of course, the cartilage is not as strong as the bone. So sometimes, therefore, it bends a bit. So it can be a bit knobbly, right? And therefore, and that's the cause of it, because the cartilage is softer, right? And of course, sometimes it may break if you have a bad fall a little bit more easily than more healthy bone, okay? And some patients affected, or children and adults affected with Olliers can have only 1 or 2 bones affected, and very mild. And other people can have many more bones affected. And that really isn't understood as to why some people are more affected than others. But essentially it's the same process. The severity of it may be different, but from what we can see down the microscope, and we know about what we know about this gene now, it is more or less the same. So just to summarize that, it's a rare disease. So a lot of doctors want to do their best, but they just don't have the experience, and they may not have the knowledge, and therefore it's important to get a diagnosis and to get to the specialist centres. And even there, people, I was speaking to Dr. Farhan there recently, and even he sees a lot of patients, but actually he tells me he's only got 4 or 5, but that's a lot of patients with Olliers, right? And so, and I'll come back to that in a moment, we now know, since 2011, the misspelling in the genetic code is understood. So that's knowledge. So at least, I'm not claiming we found the cure for it, that there's huge advances, but at least we know what the basis of the problem is now, okay? So you can move one step forward to identifying how you can address it. I want to emphasize that this is not an inherited disease. It occurs after the sperm and the egg come together, maybe only a few days later, but it comes after that. And I think what's really this conference is what do you want out of this conference? And even if you just start to think about what you want out of the conference, that is worthwhile. I don't think we're here that we'll have all the solutions, but if it answers some of your questions, and as a community, as a medical community, and as a patient community and families, if we can address really what is it you want and that you would find valuable, because sometimes the doctors don't know really the minor things. We might, as doctors, consider them, well, that's not a problem, but actually that some of these things might be the largest problem that families and parents and friends face. So that's one of the reasons that we're here. So clearly getting a diagnosis early from a specialist unit and with people with some knowledge is very helpful, because then at least you can stop worrying, you can look forward, you can address the problems. So I think that is important. And there are specialist units, but I think that we could increase awareness, and maybe with the specialist units, we could have a greater network of doctors across the UK with the knowledge base, and that other doctors might know to whom patients with Ollier's and Maffucci could be referred. And many of the doctors, the surgeons who are operating on children, it takes a lot of time to operate, but also very well informed nurses and other healthcare workers, like hand surgeons or occupational health services, and special needs in terms of maybe we need a network to include people with that specialist knowledge, because that's what you need to answer your questions, and you need the support. But in a way, I think the medical community and with Charlotte and the Maffucci and Robin Trust, we need really to work together to make that happen, because as families, it's difficult to drive it by yourselves, but actually in the NHS, it's difficult to do it without you, because you're the people involved. New therapies for this disease, I mean, surgery has advanced quite a lot, and Ali will talk to you about surgery that he does. There are inhibitors, drug inhibitors, that block the effect of this mutation, and there was great, when anything is new, people always think there's going to be an amazing change. These inhibitors to date have not been as successful in the treatment of cartilage tumours as some other tumours. But I think that there are still developments being done on those drugs, and we are using those drugs, we're also getting a better understanding of how this disease develops and how it can be looked after. One of the studies that I've, with my group, have started because of our interest in IDH1, we haven't really involved children, but we have now a UK-wide network of patients with cartilaginous tumours. And we are following all of these patients in the NIHR, National Institute of Health research study, where everybody with a cartilaginous tumour can join. And so we follow their progress for the plan is for the next 5 to 10 years. And any tumour that's taken out of a patient, we will do very in-depth genetic analysis of those. And to date, with the 100,000 Genomes Project, the numbers of cartilaginous tumours that patients we've recruited into the study with cartilaginous tumours must be close to 100, okay? We're also, even in the national study where we're now going to be following for patients for 10 years, we've collected again nearly 100 patients where we're following them in depth. And the plan is we also take their blood sample, and we take their blood sample every 3 months, which is a bit of a pain. So everybody signs up very enthusiastically, and then they get a bit fed up with us when we keep coming back to them. But it is a useful study, We haven't included children in this study because of the difficulty of taking blood samples from children repeatedly. So, but I would say that if anybody is having surgery and you're not approached about the study, or if children are having surgery while they're asleep, we could get blood samples from them and include them in this study. And so what we are using this for is that we're using it to monitor. We now find that we can identify this IDH1 abnormality in the blood if the tumor is becoming more aggressive, okay? And that is very useful in terms of monitoring patients. It's in its early stages. We had a preliminary study, but we've opened up the trial close to a year ago. That is, and anything we learn from regular cartilaginous tumors, of course, then can be fed back into the Olliers syndrome patients. So that is an advance. And I suppose, I mean, one of the questions I suppose is which Charlotte and you need to discuss is, I think at a medical level we need a stronger network of specialist doctors and nurses and healthcare workers around the country. But I suppose in the UK, would you benefit, would patients benefit from a national registry? Yeah, in terms of, and this now people can put in their own information and it can be kept anonymous, but you can put it in so you're not bothered by doctors continually coming back to you. So if there's an event, something happens, you can add that so we can gain more information. So one of the things I would be cautious about and add a word of caution is to be careful about signing up to things unless you know that it's going to be done properly with the appropriate ethical approval. Because I mean, we all hear about Facebook's now being hacked and everything. So I think it is important to, particularly if we're putting children information on a website or anything, that it's done in the appropriate, under an appropriate secure system. And not to give out random information in a random way. I think that these things should, if they're best done in quite an organized, formal way, otherwise the data means nothing and nobody will ever believe it. Yeah. And so, yes, what's achievable, and I think maybe to employ a junior doctor or a fellow or a research nurse and maybe do a survey to pay, well, you have most of the information as to what people want, but actually then to really to investigate exactly what specialist centres are available in the UK might be something that we should look to the future to see how we can engage and answer those, what information is available, what specialist centres are around the country. And there are very good places, Leicester, Great Ormond Street, Manchester, there are different places, but I think we're working a little bit, we're a bit isolated and we don't talk to one another enough, and everybody could benefit, the medical community and the patient community, if we were to do that. So I'm going to stop because you now have a very eminent surgeon who needs to tell you about, yeah. Hello?
Can I just ask a really quick question?
Yes,
about
of course.
Diagnosis. In that we refer to genetics, and we've had X-rays show multiple tumours,
Yeah.
but genetics initially said, oh, we'll send bloods off, and then when they came back, he said, oh, actually, we can't get a diagnosis from blood test, it needs to just be a tumour sample. So is it, the diagnosis is from a tumour sample rather than...
The diagnosis is from a tumour
Yeah.
sample.
Lovely.
You can, sorry, excuse me, yeah. So you can get it from a blood sample, but in a child generally, one would at the moment, the standard of care, you can look for it in blood, but the general standing would be to look for it in tumour. Certainly in the NHS, that would be the appropriate standard. Yeah.
Can I add something to that? So the IDH1 and the IDH2 mutations you not likely find on the blood, but I think when the clinical geneticists asks for a blood test, she's also trying to rule out other things.
Yes.
As you just heard, there are other diseases that are characterized by enchondromas that do have mutations that will appear in the blood.
Yes.
So this is what we do, what we're trying to do when we ask for a blood sample, is to rule out other things. Because a lot of times, Ollier-Maffucci will end up being the diagnosis of exclusion because you don't have a blood test to do the diagnosis of Ollier-Maffucci. So you want to make sure that you are not missing out multiple exostosis like the one that was showed there, that will show up on the blood sample. So this is why we, and the other thing that we may ask also is a urine sample, because there are other enchondromatoses that will show abnormalities in the urine. So it's not that we are trying to make the diagnosis of Ollier-Maffucci, but that we are trying to rule out these other ones.
Thank you.
I understand what you were saying about, you can spot this diagnosis or try and start this diagnosis as a child. And quite a lot of people, my husband's experience, but a lot of people had that diagnosis many, many years ago and don't know where the access is to the notes and things like that. Would you then recommend, can you make a conclusion that it's definitely one or the other just on radiological evidence, or would you say you need another biopsy to definitely prove?
Well, there's two things. I think the pathology tissue should be there almost forever. So it should be still possible if there's been a previous biopsy. That material is generally kept forever in the UK. So
So to go back to the original hospital?
yeah, and it can be sent to a specialist unit to have the test. But as the doctor there from America was saying, yes, you could have a blood sample to exclude it to all the other worrying things. But if you've had a sample taken, that should be retrievable, it can be sent.
And it certainly sounds like there's two peaks, one at childhood where there's a lot of operations, and then, but I'm not sure, and this is what we were trying to find out personally in terms of, we may talk about it later, but how does it impact on adult life? And I guess that's where you're saying, maybe monitoring, maybe do this blood test.
Yes, and I think monitoring, and I think yes, as you said, while a child is growing, there's all those problems of growing and the bone maturing, and then later there is a risk of the tumour becoming more aggressive, and that it can be measured by imaging. Of course, pain and patient symptoms is always a very good indicator, but the trial that we're doing at the moment is to try and establish whether that blood test can be used universally, and as a way permanently rather than lots of x-rays.
So it really depends on patient reporting in terms of